All right, well, thank you all for joining us today for our second Lunch and Learn of the fall semester. I want to quickly go over a few items for today's session before we begin. If you can please ensure that your microphone is on mute to avoid any disruptions, but please feel free to use the chat to communicate throughout the presentation if you'd like. You can also drop questions in the chat during the presentation for us to address at the end. When we open up Q&A, you can either use the chat to send your questions, or you can use the raise your hand nonverbal communication feature. To use that, you will just click participants on the toolbar, and raise hand will be located at the bottom of the participants list. I will call on those with their hand raised to unmute yourself to ask your question, and after you are done, you will just unclick raise hand. I will also ask that you all turn off your cameras during our presentation, but you may turn them on when we begin Q&A. Last thing to note is that this session is being recorded. Before we get started, if anyone has any announcements or upcoming events they'd like to address, I do welcome you to go ahead and unmute yourself and share. All right, looks like we don't have any announcements, so I will go ahead and turn it over to Leslie Johnson. She is a professor and leads the Planning, Evaluation, Education, and Research team for the school, and she will be introducing our speaker, Reem Aly.
Welcome. I am very pleased to introduce Reem Aly. I've had the pleasure of working with her at the Health Policy Institute of Ohio. She is the Vice President of the Health Policy Institute of Ohio and has served as their in-house legal counsel. She joined HPIO in 2011, and she has led the efforts there to provide Ohio policymakers and health stakeholders with high-quality, objective work that's relevant to policy decisions with a focus on health equity, maternal and child health, and the intersections between the healthcare system and population health. She co-leads the development on HPIO's Health Value Dashboard, which has become a really critical tool to a number of us, including policymakers, that measures Ohio's progress towards health value. She also serves as adjunct faculty to Ohio State University's College of Public Health. Prior to joining HPIO, she worked as a consultant with Nationwide Children's Hospital, also with the OCLC Online Computer Library Center, and with Bricker and Eckler law firm. She holds a law degree and a master's in public health administration, and a bachelor's in psychology and international relations from that university down the road from us in Columbus. She was named as one of the 6 inaugural recipients of the Academy of Health 2013 Presidential Scholarship for Academy Health Institute on Advocacy and Public Policy. She's going to talk to us today about eliminating racism and advancing equity related to our healthcare, looking at Ohio health disparities, inequities, and the relationship between racism and health, and the action steps that can be taken to eliminate these inequities. Please welcome Reem Aly from HPIO. Thank you.
Thank you, Leslie. Hopefully everybody can hear me. Thank you for that lovely introduction and the opportunity to share some of our work here at HPIO. Most of us are working remotely at HPIO, which has created interesting presentations, interesting meetings. So just as a heads up that I do have some construction happening in my house. If you hear some background noise, I apologize. I try to get as far away from it as possible. Oh. All right, so for those of you who may not be familiar with HPIO, we are a small nonprofit, nonpartisan organization, and we were founded and are currently still funded primarily by philanthropy. Here you see our vision and mission. We partner with other stakeholders to provide the independent and nonpartisan analysis needed to create evidence-informed state health policy. Our primary audience at HPIO are state policymakers, so that includes our state legislators, those within the General Assembly, as well as leadership and staff of the state agencies, of course, the governor's office, and various state boards and commissions. Here you see our core funders. Again, many of them are foundations from across the state, and our core funders are, oh, it's advancing without me asking it to advance. Our core funders are among our core funders are those who actually founded us back in 2003. I want to start off by giving you an overview of how the US compares to other nations on both overall, what we call overall indicators of health and healthcare spending. So you see here that compared to other nations, the US has a lower life expectancy. And what that means is that people in the US are expected to have shorter lives than people in other nations. And then what you might also see with that red bar towards the bottom is that our healthcare spending in the US is much higher than that of other nations. So we are living shorter lives and spending more on healthcare in the US as compared to other nations. This is just important contextual information for how we do in Ohio. So this is our health value dashboard, a tool that we created to track Ohio's progress towards improved population health outcomes and healthcare spending. We analyze about 100 measures in the health value dashboard and helps us assess whether we are moving in the right direction on population health and healthcare spending. Our analysis in the dashboard, we actually partnered with researchers out of Ohio University Voinovich to assist us with this analysis. Dr. Ani Ruhil, I think I saw him on this presentation as well, has been our partner for many years now, and is actually going to be assisting us with our 4th edition of the dashboard, which will be released in the spring of next year. We develop this dashboard every 2 years. We are committed to putting it out every 2 years. So getting to how Ohio ranks, we are 46th out of 50 states on health value, which is 50 states and DC on health value, which is a composite measure of our population health outcomes and healthcare spending. There are many factors that impact how we do as a state on overall health. Researchers have estimated that approximately 20% of our health can be attributed to access to high quality clinical care. And you can see here that Ohio actually ranks relatively well on access to care. We are 18 out of 50 states and DC, but that also includes our performance within the healthcare system. So the quality and efficiency of the healthcare system. And there we rank 36th. So in that 3rd quartile out of 50 states and DC. About 30% of our health is influenced by health behaviors. And we are really quite in the bottom pack, bottom quartile on issues related to supporting healthy behaviors within our public health and prevention domain. And then 10% is attributed to the physical environment and 40% to the social and economic environment. And again, you can see that Ohio performs poorly across all of these factors that impact our overall health. One thing we often say is that access to care is necessary, but is not sufficient to good health in our state. And you can see that on these factors that influence our overall health, Ohio does perform poorly relative to other states, which is why we see our health value rank being so low. Now, we identified 3 primary reasons for why Ohio ranks so poorly, and I'm going to focus the discussion today on that top reason, that too many Ohioans are left behind, and that not all Ohioans have the opportunity to live a healthy life. And we'll take a closer look at Ohio's troubling gaps in outcomes. The other 2 reasons we identified were that our resources are out of balance. We spend more on downstream healthcare services, the treatment of conditions versus prevention. And then addiction, as we've seen over the past really decade, is holding Ohioans back with the opiate crisis that's happened in recent years. Zeroing in on the driver that too many Ohioans are left behind, here you see our ranking on various indicators that are included in the dashboard and an estimate of what it would look like if we didn't have gaps in outcomes on some of these indicators. So for example, when you look at child poverty, where overall as a state we are 35th in the 3rd quartile in the bottom half of states, if we look at the disparity across child poverty, what we found was that over 112,000 Black children in our state would not be living in poverty if the gap between white and Black children in Ohio was eliminated. You'll note that there are gaps associated with income level and also with disability status. And that just highlights some of the disparities that we see in Ohio. Within the dashboard, we also take a closer look at those disparities and inequities through a series of equity profiles where we disaggregate data by race, ethnicity, by income or education level, and disability status. Taking a look at what are some of the factors that are driving our overall poor health outcomes. So I'm not going to spend too much time on that this afternoon, but encourage you to take a look at the dashboard and those equity profiles in the dashboard for more information. Now, before I move into a greater discussion of the disparities that we see in Ohio and the inequities we see and our focus on eliminating racism, I just want to make sure that we are all on the same page when we talk about equity and that we have a common understanding. Here you see a definition of equity or health equity that we developed in partnership with HPIO's Multi-Sector Equity Advisory Group. The definition highlights the what and how of health equity. So when we think about what health equity means, it's that everyone is able to achieve their full health potential. And to achieve this goal or objective, it requires addressing historical and contemporary injustices and removing obstacles to health, which include things like poverty, discrimination, including racism, and their consequences. Typically in discussions, we frame health equity around health inequities and health disparities. Those are 2 terms you're going to hear me say quite often throughout this presentation. These 2 words are often used interchangeably, but they really are very separate and distinct concepts. So when we talk about health inequities, we're really talking about the differences in the distribution of or access to social, economic, environmental, or healthcare resources, such as differences in access to health insurance coverage, to healthy foods, to a job that pays a self-sufficient income, to adequate, stable, quality housing, and to quality education. These inequities are often considered the underlying drivers of health disparities. And then when we talk about health disparities, we're really talking about the avoidable differences that we see across across population groups on health outcomes. So this would be, for example, differences in hypertension, in infant deaths, in life expectancy between communities of color and white Ohioans. Now I'd like to just provide an overview of some of the troubling gaps in health outcomes that we see across Ohio. You may have seen a version or iteration of this map in other presentations or in other materials, but what this map shows is that there is a gap of more than 29 years in life expectancy in Ohio, depending on where you live in the state. The green tracts, census tracts, that you see are those that have the highest life expectancy in the state, and then the ones that are in red are those with the lowest life expectancy in the state. So the map shows that the top and bottom census tracts for life expectancy in the state range from a low of 60 years in Franklinton, which is in Franklinton County, to a high of over 89 years in Stowe area of Summit County. You can be living in the same county in Ohio, maybe even in the same city, and the life expectancy in your neighborhood may be drastically different than the life expectancy in a neighborhood that is just a few miles away. When we looked at the census tracts with the highest life expectancy and those with the lowest, a very troubling pattern emerged. We found that the census tracts with the lowest life expectancy had a higher percent than the state average of Ohioans with disabilities, as well as Ohioans who did not graduate high school. The average income in these neighborhoods was less than half of the state household median income, and the census tracts with the lowest life expectancy had a higher percentage than the state average of Ohioans of color, specifically Black or African American Ohioans. On average, Black Ohioans in our state are expected to live 4 years less than white Ohioans in our state. Black infants in our state are dying at a rate 2.5 times greater than the rate for white infants and 2 times greater than the state's overall rate of infant mortality. And as you see here, communities of color are more likely to report fair or poor health as compared to white Ohioans. The health disparities and inequities experienced by communities of color have really only been exacerbated by gaps in outcomes during the COVID-19 pandemic. In May, we released a brief that described the disparities that we see in COVID-19 by race, presenting publicly reported data from the Ohio Department of Health by race and ethnicity. And we just recently updated that brief in August. So I'd like to share a few of our findings from that. What we found when we looked at more recent data is that the troubling disparities we saw when we first conducted our analysis by race ethnicity in May have only worsened. This figure compares COVID-19 cases, hospitalizations, and deaths for Black and white Ohioans relative to their proportions of the state's total population. What this shows is that our Black or African American community in Ohio is overrepresented in COVID-19 cases, hospitalizations, and deaths. Black or African American Ohioans account for 13%, about 13% of Ohio's population, but make up about 30%, as you can see here, of COVID-19 hospitalizations. On the other hand, white Ohioans make up about 82% of the state population, but less than 57% of COVID-19 hospitalizations. Another deeply troubling data point is that Black or African American Ohioan COVID-19 deaths have already surpassed total deaths in 2018 from many other leading causes of death. And with these numbers only increasing, COVID-19 is likely to become a top 3 leading cause of death for Black or African American Ohioans in 2020. When we talk about COVID-19 disparities and other health disparities experienced by communities of color, they really are just the tip of the iceberg, or in other words, indicators of more deep-seated issues that communities of color are facing that need to be rectified. And those deep-seated issues are grounded in racism and other forms of discrimination. And the research evidence is very clear that racism is a primary driver of the inequities and disparities experienced by communities of color specifically. I want to pause here for a second because I'm going to elaborate on this more, but I want to share that it's important that when we talk about these inequities and disparities, it's understood that these gaps in outcomes faced by Ohioans of color, and specifically our Black and African American community around COVID-19 and other health outcomes are not a result of genetics. They are not a result of behaviors, and that the evidence demonstrates that these gaps in outcomes are a result of hundreds of years of racist policies, practices, systems, and beliefs. In June, Governor DeWine made a statement on racism and its persistence and continuing impact, and really called Ohioans to action to address racism. And he has reiterated these statements over the past several months. The link between racism and health has been grabbing the nation's attention, particularly as we see how COVID-19 is impacting communities of color, and in light of protests and public calls to address racism and police brutality following the recent deaths of George Floyd, Breonna Taylor, Ahmaud Arbery, among many others. HPIO recently released a brief that goes into detail on the relationship between racism and health. In talking about racism and ways to dismantle racism, it's important to understand the levels at which racism operates within our society. This is a framework that we use at HPIO that others can also use to help explain and better understand how racism takes shape within our society. That bottom rung, internalized racism, describes an individual's privately held beliefs of prejudice, oppression, and privilege regarding their race or the race of others. This can manifest in feelings of white superiority, or in a person of color feeling inferior based on standards that have been accepted by the general public. Interpersonal racism describes when individuals, through their interactions with one another, act on beliefs of racial prejudice, stereotypes, oppression, or privilege. For example, through indirect or direct acts of unfair treatment, bias, or violence. This is what is most commonly thought of when we talk about discussions of racism, is it's that interpersonal level, that interaction between one individual and another. We move up this ladder to institutional racism, which describes when beliefs of racial prejudice, oppression, or privilege are acted on or perpetuated by institutions or organizations. This is, for example, when we see fewer people of color being hired or promoted to leadership positions within an organization. And then there is structural racism, which occurs within and across systems in society. Structural racism leads to things like disinvestment from communities of color through historical practices of residential redlining and even present-day gentrification. Most conversations, as I noted, often focus on the internalized or interpersonal racism rungs. However, systemic racism, which includes institutional or structural racism, is an even more pervasive driver of the gaps in outcomes, the poor outcomes that communities of color face. And it's important to note that when we talk about racism, it encompasses things that are both intentional and unintentional. Intentionally racist, directly racist, and then things that are done intentionally either at the individual, group, or system or structure level that build upon racist policies and practices and have a disparate impact on communities of color. The figure you see here outlines the relationship between racism and health. Racism impacts our health outcomes in many ways, directly through trauma, through policy and system inequities, through health behaviors. And this is a more detailed version of that same framework, which highlights that the relationship between racism and health is incredibly complex and interwoven. I'd like to break this down for all of you a bit more. First, I want to provide an example of how racism through trauma and toxic stress impacts the poor outcomes experienced by communities of color. And what we find is that toxic stress results from prolonged activation of the body's fight or flight stress response system. And toxic stress or experiencing toxic stress can be caused by traumatic or adverse events and environmental factors, including experiencing racism and racial microaggressions. So that can create a buildup of stress or toxic stress, which then repeated exposure to these traumas can lead to a wear and tear effect that results in physiological changes within the body, cause a deteriorating effect on a person's nervous, endocrine, and immune systems. And over time, this wear and tear effect contributes to poor health outcomes directly, including things like high blood pressure, heart disease, stroke, depression. Racism also leads to what we call policy and system inequities across the many factors that impact our health, which then contribute to poor outcomes, poor health outcomes for communities of color. For example, data demonstrates that communities of color face implicit biases and racial discrimination within the healthcare system, and that communities of color are underrepresented within the healthcare workforce. As an example of this, Black patients were often denied treatment in the past because of their race and were subject to both racist and unethical medical research practices such as the Tuskegee study, and that's the picture that you see here, which was essentially an experiment of untreated syphilis in Black men lasting a period of more than 40 years. Even in clinical care today, studies have found a majority of white physicians implicitly hold anti-Black and pro-white beliefs. In addition, the health concerns and questions of patients of color are often written off or not taken as seriously, resulting in disparities in both accessing care and treatment. A good indicator of this is what we see with maternal mortality, where Black women are dying at a much higher rate than white women from maternal complications or maternal related issues. For these reasons, people of color have an understandable mistrust of the healthcare system and are less likely to engage with the healthcare system. And this also contributes to the poor outcomes that are experienced by communities of color. As another example within the criminal justice system, racial inequities are deep and systemic, dating back to slavery, to Black codes, and convict leasing. Black codes were criminal codes meant to restrict the activities of African Americans. Convict leasing was a practice of leasing incarcerated people to plantations and factories after the Civil War. These inequities are also rooted in more recent history, such as the war on drugs. And from the 1960s to the 1990s, there was bipartisan support for a series of tough on crime policies. These policies resulted in dramatic growth of our prison population. And we term that as mass incarceration, and that disproportionately impacted men of color. Now, nationally and in Ohio, Black or African American people are incarcerated in state prisons at more than 5 times the rate of white people. And this is despite the large disparities in crime arrests related to drugs or drug crime arrests. What we found is that drug use and addiction prevalence are actually pretty similar across racial and ethnic groups. So we see 5 times the rate of incarceration, and yet drug use rates are very similar across racial and ethnic groups. The impacts of these racist policies and practices directly lead to poor health outcomes for people of color, and they also have a lasting impact on families and on entire communities, preventing those who have been incarcerated or who have a felony from getting jobs once they exit the criminal justice system, can also restrict their ability to vote, and again has severe impacts on the health outcomes, not just of that individual, but also their family and community. One of the other important concepts to understand is that the impact of racism is both cumulative. It compounds within a person's lifetime, and it compounds across generations. So as you can imagine, somebody who has been at the receiving end of some of these policies and practices is going to be at a disadvantage when it comes to their caring for their families and setting their families up for self-sufficiency and for being able to thrive, setting their families and children up for being able to thrive. So the impact of racism, we say, is cumulative both across the life course and across generations. We know that racism has put in place and maintained obstacles to health for communities of color in the US for more than 400 years, and work to address the cumulative impact of racism is daunting, but improvement is very much possible. So to support efforts to eliminate racism, HPIO adapted the 4 levels of racism framework that I reviewed earlier to create the action steps to eliminate racism and advance equity framework that you see here. And this diagram outlines how individuals, groups of people, public and private organizations, and state and local government can work to eliminate racism in all its forms and advance equity. At each level of this framework, the ultimate goal is to eliminate racist beliefs, acts, policies, practices, and structures, as well as to extend leadership and power to and with communities of color. There are also specific action steps associated with the diagram that I just shared that all Ohioans can act on to eliminate racism. So just a few key themes from these action steps to highlight is the need to acknowledge racism as a crisis and as a driver of health disparities and inequities. Apologies for the background noise. This really does set a level of honesty and accountability that is necessary to engage in equity conversations. Other key action steps that you can take or encourage others to take is to educate yourself or to assist in educating others on the impact of racism. If you are a person of color, it is important for you to take time and allow yourself to heal from trauma that you may have experienced or that your family or community may have experienced. Another key action step is to advocate for policy change. Or even within your organization to advocate for policies, practices, and programs that produce equitable outcomes. And then also to be intentional about collecting data that not only tracks whether an individual has experienced racism, but that can also allow an organization or policymakers or even individuals, if you're within a student organization, to track whether or not the outcomes that you are trying to achieve are actually equitable across racial and ethnic groups. So being able to disaggregate the data that you collect to see whether you are producing as an organization, as a group, as a state agency, as a policymaker, equitable outcomes for all Ohioans. Now, to overcome the status quo and eliminate these existing deep-seated racist policies, practices, beliefs, interactions within society, it's critical that these themes are acted on and sustained over time. It's taken us 400 years to get to where we're at, where we have layers and layers of policies, practices that perpetuate inequitable outcomes for communities of color. It is going to take us time to dismantle racism within our society. I wanted to highlight what individuals and groups can do. These are the action steps that I just went over, those same themes of educating yourself. First, acknowledging that racism is a crisis, it's an issue, it's leading to poor outcomes for communities of color, educating yourself on the impacts of racism, taking time to heal, and then advocating or being an ally to efforts to dismantle racism. In addition to these action steps, there are several important state documents that serve as additional resources to dismantle racism and advance equity in Ohio. And I just want to briefly highlight some of these resources that you can go to. There is the State Health Improvement Plan, and we at HPIO fondly call this the SHIP, which is a tool to strengthen state and local efforts to improve health, well-being, and economic vitality, as well as to advance equity. The State Health Improvement Plan, or SHIP, includes a large number of strategies that have evidence of decreasing disparities and inequities. And the SHIP also sets bold and necessary targets to eliminate disparities and inequities across key measures within 10 years. I shared a quote from Governor DeWine earlier, but in April of this year, Governor DeWine also formed the Minority Health Strike Force to address the disproportionate impact of COVID-19 on communities of color. This strike force issued 2 reports an interim report with recommendations to eliminate COVID-19 disparities, and then a blueprint which provides a set of recommendations to eliminate racism and broadly address the health disparities and inequities faced by communities of color. I shared two examples of the policy and system inequities experienced by communities of color, but this blueprint goes further, providing recommendations to address many other inequities. And HPIO was commissioned to facilitate development of this blueprint. And this blueprint was released in August, along with the executive response, or Ohio's executive response to the blueprint, and that was issued by the DeWine administration. It outlines policy actions that state agencies have committed to take to eliminate health disparities and dismantle racism. There are a series of 10 commitments that the governor and his administration have issued in this executive response. So if you haven't had a chance to look at it, it is certainly worth a review. I mentioned the SHIP, but want to share what it looks like to have a target for eliminating disparities. And so here you see an example of a target from the State Health Improvement Plan on premature death. There are years of potential life lost. And you'll note that orange is represents Black non-Hispanic Ohioans, and blue represents all Ohioans, that blue line, and you'll see that there's a large gap in outcomes on this indicator. So Black or non-Hispanic Ohioans are much more likely to experience what we call premature death, or have potential life lost or years lost as compared to other Ohioans. And the SHIP sets out specific target for closing that gap within the next 10 years. We have been very encouraged at HPIO in recent months to see state and local leaders, health systems, businesses, academia making bold statements, drawing the connection, the direct connection between racism and health. And we're very hopeful that actions that have been taken more recently will be sustained over time to advance equity for communities of color. And I want to note that although our action steps framework is specific to dismantling racism, it can be applied to other forms of discrimination. And in order for us to achieve equity in Ohio, we certainly need to tackle racism, but we also need to make sure that we are addressing other forms of discrimination that are experienced by Ohioans. And with that, I think I'm right on time, and I'm happy to take any questions that you may have.
Thank you so much, Reem. Yes, anyone who has questions, please feel free to either drop them in the chat, or you can use the nonverbal communication feature, raise hand. You'll find that button in the participants list at the bottom. So please feel free to do that, and you can turn your cameras on as well. Reem, I have a question from Nora here. She's saying, thank you, this was very informative. Has there been, or is there any planned consideration of disparities of caused or contributed to by environmental factors, such as waste disposal, industrial area proximity, job hazards, water contamination, etc.? Example, environmental racism.
Sure. Yes, so the Minority Health Strike Force Blueprint does go into some of the environmental factors, or the inequities we see within the environment that contribute to poor health outcomes. So it does outline some specific recommendations, particularly around job hazards. And this is not an area that HPIO has dug deep on. We have done some work on lead exposure and the impact of lead exposure, particularly on children of color. But there are a few key strategies identified in the Minority Health Strike Force Blueprint, and then also in the State Health Improvement Plan around environmental factors that are driving inequities among communities of color. I see another question in the chat box. So Mackenzie, I'll go ahead and answer that from Greg Moore. And that question is, can you say more about life expectancy gaps across the state? The Franklin County numbers are striking. What we see within Franklin County is similar to what we see across the state. So if you, we didn't do an analysis of within county life expectancy disparities or gaps, meaning which county has the biggest gap in life expectancy from one census tract to another. But what we did find is that the 29 number is it's like around that for other counties in the state, even counties that have a predominantly white population, we find very large gaps in life expectancy that might be driven by income level or disability status. So the gaps in outcomes that we see around life expectancy are pretty, are ones that we see across the state. I don't know if that was answering your question or helpful.
I think it was. Thank you, Reem, and I apologize. I was still on mute when I went to move on to
okay.
Sam, if you would like to unmute yourself and turn your camera on to ask your question as well.
Sure, thank you. So yeah, thanks so much for presenting all of this, Reem. I'm used to seeing this sort of data for a national level. So it's actually...
Sam, you're muted now.
I'm sorry, I'm using this on my phone, but yeah, as I was saying that it's great to see all this data. I'm used to seeing it, you know, at a national aggregate level. So it's really helpful to see it at a state level. And the facts you have behind racism being a reality were equally, you know, useful. But at the same time, while your organization is bipartisan, this strikes me as a very political issue. Both healthcare in general and racism strike me as very political issues. And of course, there's definitely bipartisan work on them, as you mentioned, with Governor DeWine's administration. But I'm just wondering how, from an organizational standpoint, do you navigate the politicization of some of the facts and, you know, evidence-based suggestions you make?
Sure. So that is the truth, and it really is an indicator of why racism is systemic. You don't get the visceral reaction when you talk about, for example, discrimination against people with disabilities or discrimination by income. You get that visceral reaction a lot of times when you talk about racism for those who maybe may not be convinced that it exists or that it is driving poor health outcomes. We, as an organization, are grounded in the evidence. And what we do is we provide usually policy options or policy recommendations. We don't ever advocate for a specific piece of legislation or for a specific policy. What we do is we present the information, we present the data, we present the evidence, and then it is really up to other advocates to make that appeal to state policymakers or to others that they are trying to convince to take one specific type of action. So as long as we are grounded in the evidence and grounded in the data, we are comfortable in walking into what has turned into a political issue or has been a political issue. But I have to say that as an organization, we have also evolved. And when we were first doing work on equity, there was a lot of reticence, not necessarily within the organization, but certainly outside of the organization, to have a specific focus on racism. We have seen that the environment has shifted. And I think also our thinking as an organization has evolved to recognize that there needs to be an explicit focus on racism, given the disparate impacts we see among communities of color, given the deep-seatedness, I don't know if that's a word, of racism as a systemic form of discrimination experienced by communities of color. So it's not been something that has happened overnight. It has taken an evolution both within our organization, and then we're seeing that evolution happen outside of our organization as well.
Thank you, Reem.
Thank you.
Oh, sorry, go ahead.
Oh, I was just saying thank you.
Sure, thank you for that question.
Yes, we have a question from Matt in the chat as well. Matt, so thank you for your time. You mentioned in your presentation that lack of preventative care engagement versus diagnostic care is a big problem in addressing racial health inequities in Ohio. Does the SHIP report have particular recommendations in solving this issue, or your thoughts on solutions in general?
Yes. So you noted, you might have, and you might remember the pie chart that I shared with you that shows the various factors that impact our overall health. And what we find is that there's a lot of focus on the healthcare system, that treatment side, that diagnosis side, but not a lot of focus on the social, economic, environmental factors that impact our overall health. So the State Health Improvement Plan takes a very comprehensive look at health, identifying has a number of priority topics, being one of them being housing, another poverty, another adverse childhood experiences. So really taking a more comprehensive or holistic look at what impacts health, and then identifying evidence-informed strategies that can move the needle on those outcomes. So improving financial stability, or improving the ability for Ohioans to make a self-sufficient income, preventing adverse childhood experiences. So it definitely takes a prevention lens to the issues that Ohioans are currently facing, and that communities of color and other communities that are at risk for poor health outcomes are facing. Another theme in the State Health Improvement Plan, and you'll see this in the Minority Health Strike Force Blueprint as well, is the need to target and tailor strategies to those communities that are most at risk for poor outcomes. So a strategy may actually be evidence-based for improving an outcome, but may not have been evaluated for a specific community that is at risk. So for example, communities of color. But if you target and tailor a strategy to those communities, you are more likely to see positive results.
Thank you. Brian also has a question in the chat. In reference to institutional and structural racism, how does this affect Black veterans' health? Is there any evidence of health inequities or disparity for Black veterans in the VA system or at the local government level?
Thanks, Brian. I do not have specific knowledge of disparities within the VA system, but I would venture to say that you are going to see disparities across communities of color within the VA system. I can't speak to that specific data. Happy to follow up though.
That's okay. Thank you, Reem. I appreciate the honesty and not being able to answer that question there. But imagine, that is correct, and unfortunately that Black veterans do experience inequities. I have a question as well from Lorraine here, kind of related to Nora's in the environmental aspect. The impact of climate change is disproportionately felt by communities of color. Is the research of your institute addressing the climate crisis?
We have not yet. So we have not produced any publications specific to climate change or the environmental impacts of the climate crisis on inequities and disparities, we did release a report called the Social Determinants of Infant Mortality Report that does associate air pollution with poor infant mortality or infant outcomes, so increasing infant deaths. So we have done a little bit of research in that area, but not specifically on the impacts of climate change.
Thank you. Ani also has a question here, and we'll have time for maybe one more after his. He's asked, how far behind has COVID-19 have likely left us in terms of health inequities and overall health value?
Ani, that's a great question, and one that probably we will ask you to help us explore. We expect that it is going to exacerbate the disparities that we see both in health outcomes and then also inequities. So, we've seen already that COVID-19 has hit communities of color harder than other racial or ethnic groups, and that COVID-19 has lasting impacts, meaning that you can't necessarily assume that somebody is going to fully recover from COVID. We still are unclear about what the long-term health consequences of having COVID are. And then on the other factors that drive disparities, so when it comes to employment, when it comes to education, we also know that communities of color are likely to be more hard hit by COVID-19 than other racial or ethnic groups, particularly Black or African American Ohioans. And so we won't see the data for a few more years on this issue to really assess fully and comprehensively the impacts of COVID-19. But I think it is really safe to assume that we're going to see a widening of gaps in outcomes because of this pandemic.
Does anyone have one last question here? We have time for maybe one more quick question. Okay, I don't see anything coming in, but I want to thank you so much, Reem, for presenting to the school today. I want to remind everyone on the call to please save the date for our next session on Friday, October the 23rd, with special guest Yvette McGee Brown. She is the partner in charge of diversity, inclusion, and advancement at Jones Day Law Firm. Again, thank you so much, Reem, for taking the time to share this information with us and for all the work you do in advancing health equity in Ohio.
My pleasure. Thank you.
Thank you. Well, I hope you all have a great weekend. Thank you so much for joining the session today.